Good morning, everyone. Usual rules apply. If your video is on, I will ask you questions. If you're doing the DDU, I will ask you questions. And so I'll focus on the guys who are doing the DDU first of all. Okay. This first one, it's forgive me if I put this together a little bit at the last minute, but this first case would definitely not be as long as this, but it was such an interesting case. I hope you don't mind that I'll sort of ask a couple of slides at a time and then ask the next person. So it's a little different to how the exam will work, but again, I'm just going to fire questions at you and I hope that's useful. Okay, so case one. So we've got this 45-year-old female who came to our unit with an acutely ischemic lower limb. She had an urgent thrombectomy that was done because they found this 6 centimeter occlusion in the common iliac artery on the left. So they went and did a thrombectomy. She was a little bit hypotensive afterwards, so I was put onto a metaraminol infusion and came to the ICU. She had our standard echo that we'd do, 50 times a week for query cardioembolic cause of ischemia, and 95% of them are normal. Kyle, first time to Fight Club, so you've got to kick things off.
Yep, sounds good. On the bottom right, we have a transthoracic peristernal long axis image. On first impressions, it looks like the left ventricle may be a bit dilated and globular in nature, though the function seems relatively preserved. The most striking abnormality appears to be the aortic valve. I can't see two distinct leaflet motions, and there seems to be thickening of the lower leaflet, which could be the non-coronary left coronary. Nice. The aorta, from what I can see, appears to dilate on the edge of the screen. The right ventricle doesn't seem enlarged and the function looks all right. I think the image on the top left is zoomed in on the aortic valve. Yep. And the LVOT, though it keeps going in and out of view. Just like I've run one or two times. So there's certainly thickened leaflets. There also appears to be an independently mobile mass, which can be seen in the LVOT at the end of the clip. Maybe half a centimeter or half a centimeter, and that would have a wide differential. I guess in the setting of the clinical presentation, a thrombus would be at the top of my list. Infective endocarditis would also be, but then we could look at things like an artifact, a normal variant seems unlikely, or a tumor like a papillary fibroelastoma.
Very nice indeed.
So these, the two top pictures are similar to the past, but again, the zoomed in view, a bit more clear and on axis, with findings consistent with what I mentioned previously. So the right coronary cusp also appears thickened. A color Doppler of the zoomed in aortic valve view demonstrates what looks like eccentric aortic regurgitation. I wouldn't be able to comment too much on the severity, but it seems prominent on my screen. And then on the two lower views, it looks like we have a short axis view of the atrial valve, normal TD on the 2D on the left, color on the right. Again, it's showing aortic regurgitation on the color Doppler. It looks like there's definitely some central, but also looks like there's some peripheral regurgitation around 12 to 1 o'clock. But on the current view, I don't really want to comment more than that.
Okay. Does this help your differential diagnosis in any way?
Well, it certainly makes artifact and normal variant very unlikely, and it looks like we have a pathological process. And I think thrombus and infective endocarditis would be still at the top of my list. And the fact that I thought there was non-central regurgitation would make me think more infective endocarditis and destruction of the valve.
Very nice, excellent. That's exactly what I was thinking, the same thing.
So we've come around to.
Yep, go for it.
Keep going. So we have our apical four-chamber views in the top left and top right. A part of and we got our end systolic volume on the bottom left with Simpson showing ejection fraction of 65%, and then it looks like a I think a continuous wave Doppler through the tricuspid valve in the bottom right, from what I can see on my screen. So working through them, I guess in the top left image is the most striking abnormality. It looks like in the left atrium there is a thrombus adjacent to the interatrial septum and the anterior mitral leaflet. Certainly there's echo density adjacent to that wall, which pops in and out of view. I would be worrying about thrombus, though an abscess would be a differential. And then on the top right, it looks like we have a modified 5-chamber focus on the aortic valve. And again, the leaflets are thickened. There's increased echo density. It seems to be independently mobile in nature. It doesn't change my 2 major differentials. The bottom left showing the ejection fraction 65% is consistent with my visual approximation.
Yeah, how do you know that that's an accurate measurement? So what do you, so you've got an ejection fraction of 65%. What makes you trust that number?
Well, is it what I would expect? Is one. So does it fit in with the other images I've seen in my qualitative assessment? That's yes. Is the tracing of the Simpsons biplane look like it's accurate? Again, it's a yes. Ideally, you'd see the other 3 tracings as well to map it all
Fantastic,
together.
absolutely, yeah. Just saving space. So when you say accurately, what define me what makes it accurate and non-accurate?
Well, first of all, there's going to be image quality and proper endocardial definition and ability to visualize the border. And then there's going to be appropriate tracing of the endocardial border. There's varying practice on if you trace right on the edge of the myocardium or closer to the pericardium, but as long as you're consistent across your 4 measurements.
All right. Anything else?
Not that I can think of.
Okay, no problem. How do you estimate? Right. Yeah, and how do you estimate the peak systolic pulmonary artery pressures?
As a general question, not specific to this. Yeah, so it's going to be the velocity squared times 4, and then peak velocity or tricuspid regurgitation jet plus the right atrial pressures. And right atrial pressures either come from our central venous pressure from our central line or estimated through our IVC at 5, 8, or so diameter and collapsibility. So if it's less than 2.1 and collapses, then it's 5. If it's greater than 2.1 and doesn't collapse, then it's 15. And if it's greater than 2.1 and does collapse, it's 8.
We're going to leave it at that, and we're going to move on to, actually, maybe, do you mind, otherwise I forget what I'm doing. I might just go through just those little few questions quickly along there. Mate, cracking, fantastic, clear pass, beautiful, very little prompts in there. Really like the cadence. You're going for the money straight away, but starting off with the LV, which is reasonable. And then nice differential of a thickened mass. I would have put, I don't think it's a pass or fail. I'll be putting infective endocarditis above thrombus on this one because of the irregularity of the valve. The valve is not right. What I probably should have put at the beginning is that this lady just came in with an acute ischemic leg. She's not IVDU. She's got some, she does have some bowel cancer, and she has had otherwise no symptoms of sepsis or anything at all in there. So just given the heterogeneous nature and the heterogeneous thickening, the heterogeneous opacification, the independent motions, I'd be leaning towards infective endocarditis, but that is not pass or fail, just an FYI. I think it's reasonable. I've given you some pretty shitty pitches here, but I think everything you said here was fine. An eccentric looking jet, and that eccentric looking jet with this chaotic motion coming through it does point me more towards infective endocarditis rather than thrombus, just like you said. So very nice pass there. What you said about the 2D pictures was lovely. The bottom part, so for the ejection biplane, for the ejection fraction on the biplane, as well as the borders, I think you ignore the trabeculations and ignore the papillary muscles, I think is what the guidelines say. You did say it varies depending on whether you go at the endocardial border or whether you're closer to the pericardium. I think for me, I'm guessing what you're meaning there is you're just trying to ignore the trabeculations.
Yeah.
We're always looking for the endocardial border, and how you get that is the bit that can cause dramas. Here you can see the sonographers try to ignore the papillary muscle, which I think is correct. The last part for me is the length. So the length there during the length at the end diastole in the 2 chamber should be within 5 or 8 millimeters of the length in the 4 chamber in diastole, and that tells you that you'll make sure you're not foreshortened. And the last thing I'd say is just looking at the 2D picture. I think you said at the beginning, does it match where your eyeball says? And you've also got to make sure you're not off axis. I could argue that maybe the top part of the apex should stay fixed. It's the base moves towards the apex in the heart, so that if you're scanning from the appropriate position, the apex should stay fixed. I'd argue we might be a little bit off axis here because you can see there's a little bit of a drop down in the apex there. But otherwise, very nicely answered. The right atrial pressure, I guess there are different ways of doing it. For me, it's as you said, it's about the IVC diameter and the collapsibility. Less than 21 and completely collapsing, it's 0 to 3. Less than 50%, I have it 5 to 8. When you have 21, more than 50% collapsing, that's probably 10 to 15, and then 21 mils and not collapsing, less than 15. That's at least 15, if not greater, right atrial pressure. But I think that's again what the guidelines would suggest. Anyway, much for muchness. Michael, keep going.
I don't know if it's my internet. I don't want to gaslight anyone, but my looping is not really like the frame rate's really low. Is that me or is it?
Yeah. Was it the same for you, Carl, or was it? It's working fine this end.
I kind of have to say yes, don't
I? I'll try. If I can't, I'll try.
Maybe I could try and go on to something a bit better then. All right, let me go on to something a bit better. This one's still. How about that one? Start with that one.
Okay. So this is a continuous
what's that
wave
measurement
Doppler.
also telling you?
So this is a continuous wave Doppler in an aortic, probably a apical 5 chamber view. It's looking at the aortic regurgitant jet in this patient. So we can see both the color density compared to forward flow, and we can also see the pressure half-time of the jet. Pressure half-time in this patient is 221. Less than 200 is generally severe. There are some caveats like in acute aortic regurgitation. However, this looks fairly dense, and I think we can tell from the other images that this jet is eccentric, so it's not a perfect measurement, and it can easily underestimate severity. So I wouldn't be ruling out severe in this patient just off this measurement alone.
Nice. So how else do you estimate severity of aortic regurg?
So you want to see 2D features of, especially I guess in chronic, you want to see 2D features of remodeling. So a dilated LV. In severe aortic regurgitation, you want to see the width of the jet in the LVOT. So more than 60% is severe. You can do area as well in the short axis view, but I can't remember the number. Obviously a continuous wave Doppler and then pulse wave Doppler. So looking at the descending aorta, looking for holodiastolic flow reversal of more than 200 0.2 meters per second in end diastole.
And sorry, where was that measurement taken?
Descending aorta.
Thank you very much. Yeah.
Descending thoracic aorta or abdominal aorta.
Okay.
So these are forward flow through the valve, so continuous wave on the left and pulse wave on the right. So I guess I might just start with the LVOT VTI is 22.6. So, I mean, that's, in the normal range, you'd expect that the amount of regurg this person has to elevate their VTI because a lot of blood is coming backwards and then going forwards. There's quite a big difference between the LVOT VTI and the aortic valve VTI, which suggests potentially some degree of aortic stenosis based on the dimensionless severity index. It's I can't do the maths immediately, but it's between 0.25 and 0.5, so it's in some sort of moderate category for aortic stenosis. Potentially the LVOT trace could be optimized by reducing the low pass filter and dropping the scale down a little bit, but otherwise it's okay.
Yeah, nice. How do you know about the accuracy of these measurements?
So I guess it's really important for your Doppler alignment angle to be good. You want to have a nice filled in trace like what we have on both sides. It looks a little bit like perhaps I can see a little bit better. Oh, probably in both actually. I can see that the Doppler angle's not quite perfect with the exact alignment of the LVOT. I might be getting thrown off a little bit there by the aortic regurgitant jet, but that's one of the main factors. On the LVOT trace in particular, you want the pulse wave gate to be in the LVOT and not too high up or too far into the ventricle. And you can tell that by seeing a closing click and not an opening click.
Yeah. Emma always told me be in the blue, right? So you're looking in the blue part before you get to any kind of chaotic motion. Yeah, I'll finish it up on this one from Michael.
Okay, so top left is a looping apical four chamber, which is panning through the mitral valve. You can see that mass that Kyle mentioned in the left atrium. I'm just looking to see if there's any. I don't think there's any severe mitral regurgitation on this view alone, at least. The other things that we can see in this image is down the bottom is a pulse wave Doppler of mitral inflow, which demonstrates an E wave velocity of what's probably just above 1.2, which is often indicative of either significant mitral regurg or potentially significant diastolic dysfunction. The top right is tissue Doppler of both the medial and I think the other one's the lateral, the lateral annulus, which probably both the E wave velocities are. Okay, so this is I
think this is the last one. So sorry, go for it. I'll let you figure it out.
This is a suprasternal view of the aortic arch and descending thoracic aorta. You can see on the color wave in the top left that there is some regurgitation of flow back in diastole, and the pulse wave Doppler that demonstrates fairly significant holodiastolic flow reversal, which is just below 0.2. And then down in the bottom, the last is that's the abdominal aorta, which is also a little bit tricky to tell whether or not there's much diastolic flow reversal in that image. In acute aortic regurgitation, occasionally you have an early cutoff where you don't get significant holodiastolic flow reversal, but in this case, there's not that cutoff, and perhaps this is slightly under that severe threshold, but I'd be pretty concerned given everything else in this case, especially that it's associated with what's likely endocarditis, that this is severe.
So, if I guess, sorry, probably tell me your thoughts so far. What would you like to do next?
So I think that this lady probably needs other modality of imaging. I think the thing I'd like to do first is a TOE to further characterize the morphology of that aortic valve. But I think I'd also be calling for some help with some other specialties, including cardiac surgeons, because I'm a bit worried about how severely I can't think of a good word, the severity of the morphology of that aortic valve in terms of degenerative things that have happened from the endocarditis. And if that is endocarditis, I think she needs an operation.
Okay, Rob. Baton handed over. So we went ahead and did a TOE.
Okie doke. So I guess starting from the left-hand image, top left-hand image, it looks like we're in the transgastric view to me, and we can see we're looking at the LV in short axis. Can't see any regional wall motion abnormality, and the ejection fraction is consistent with what we saw before. Moving across to the right, this is sort of an off-axis transgastric view again. It's not much that I can comment on here. It's at 120 degrees, so I imagine what we're trying to do is look through the aortic valve, but I can't say I can see that clearly. I'll move along to the mid-esophageal four-chamber. Again, that LV systolic function is in line with what we saw before, and then we're at 60 degrees, so we're at that bicommissural view of the mitral valve. LV systolic function looks much the same as what we discussed before.
If we just go through it, can you see my pointer?
I can, yes.
Cool. Tell me what walls we're looking at here.
All right, so just trying to. So if this is, it's a bit off axis, Sam, but this would be if the aortic valve is where I think I can see it, that would be the inferior lateral wall. And then the wall, which is in the far field, would be the anterior septal wall.
Yeah, nice. Give me this one down here.
Where's your pointer? Oh, yeah. So the
bottom left.
Yeah, the 4 chamber. So we have, then that would be the inferior septal in the middle of the screen, and then on the far side. Oh, yep.
Good man.
All right. So this is color flow Doppler in that midesophageal 4 chamber. A couple of concerning features here. So we can see that, again, there's that eccentric aortic regurgitation. There's also an area where there's blood flow, which I'd be concerned could be part of an abscess. And then I can see at the corner of the image that there's some at least significant mitral regurgitation as well, which I can't see which direction it's going, but it looks central there. And then
why are you calling about the abscess? Just tell me why.
Why am I calling it? So I can see that there's this. So on the right-hand image, it might not be, but there is an area of lucency that fills with color.
Great job. That's
just para-aortic.
That's good. We'll move on.
Yeah. Again, so we've got this left-hand image is the midesophageal 3 chamber, and again we can see that's what appears severe aortic regurgitation on the next right-hand image. We can see on the zoomed-in 2D picture of that aortic valve that it's grossly abnormal. Both the right coronary and the one at the top of the screen will either be the left or the non-coronary has got a independently mobile mass attached to it, which is suspicious for vegetation. And then again, we can see that there's significant regurgitation on that zoomed-in view with multiple eccentric jets. So I'd be concerned about valve destruction with perforation, but also poor coaptation causing the regurgitation.
Nice.
So this is a zoomed-in view of.
So I might just skip on that one. Just tell me about that one. What's this image showing?
So we've got a color we've put color flow Doppler across the aortic valve, and then we're doing M mode, and so we're looking at the proportion of regurgitation across that LVOT during diastole, and you can see that there's turbulent flow regurgitation that comprises the whole LVOT, which would be in a line with severe aortic regurgitation. What
are the limitations of this measurement?
So limitations are, well, for one, we've got multiple jets, and an eccentric jet could, with the Coanda effect, underestimate it. So it's best for central jets. However, in this patient, we've got multiple eccentric jets, plus probably a central one. So it is, I'd be feeling like it is a severe aortic regurgitation.
Gosh, you're too good. Let's move on. Drew, afternoon, buddy. What's this measurement? What's it showing?
Sorry, was that for me?
Yeah, please, if that's okay. Yeah, can you hear me?
Yeah, I can. So it appears that this is I think it's a midesophageal view looking at it's the pulse wave Doppler. I think it's in a pulmonary vein.
Excellent job. Great job. Yeah, well done. And what's it showing?
It's just showing some systolic blunting.
Thank you.
Yeah.
Okay, let's keep going. Are you on a phone? Is this coming through okay, or do you want me to explain it with interpretive dance or something?
My computer was having a meltdown, so
okay.
No, it's great.
Do you want me to just stick with stills for you, or should we just carry on going? It's up to you.
Why not?
Good
The upper esophageal view, it's looking at the ascending aorta. And I suspect this kind of is showing us that there's a lot of turbulent flow, mostly during systole, from what I can see. It's 90 degrees, so we won't see a whole lot of diastolic flow. On the left, we've appreciated already the pathology on the aortic valve, so I guess we won't go into that. But the ascending aorta looks dilated to me visually. I'd want to check it by linear measurements.
Okay, nice one. What's this structure that you can see anatomically up at the top above the ascending aorta?
I think it's the pulmonary artery.
Yeah, cool. Right. Joe, are you here, or you're bouncing in and out, but I see your phone's off. Are you happy to take a call?
Yeah.
Oh, go for it. Okay, what do you think of this one?
So this is a short axis view of the aortic valve with the non-coronary cusp adjacent to the intra-atrial septum, and the right coronary cusp at 6 o'clock, and then the left coronary cusp to 3 o'clock. Yeah. And I've kind of come into this late, but I can see there's a lot of vegetation on those cusps, especially the left and the non, and there looks to be a perforation behind the non-coronary cusp, potentially adjacent to the intra-atrial septum. Nice. And I'm just trying to work out whether there's a RAF there, whether there's a bicuspid, but I think it might be quite hard to tell with the infective endocarditis there, but I would be concerned that there's a bicuspid aortic valve.
Yeah, nice. What else supports that this might be a bicuspid aortic valve on previous imaging?
So there was a dilated ascending aorta.
Yeah, very nice. Aortopathy. And I think you're right. And I think we've got a fusion here of the left and the right raphe. I mean, sorry, there's a raphe there between the left and the right cusp. And the big thing, I mean, it's that kind of oval shape to the, oval shape to the opening that I think makes me think that that's where the fusion point is. Ooh.
Yeah.
How did I do that? That was excellent. Oh, anyway. Cool. So you called it a perforation. That's really interesting because we had some discussions about that. So tell me why you think it's a perforation and not an abscess.
Well, I'm just looking at that short axis view. I can see that it feels like the leaflet cusp has almost dehissed off the side of the annulus. So from that angle, it does look a little bit more like a perforation. I'd expect the abscess to go into that mitral curtain, or that it's not the mitral curtain, it's almost into the intra-atrial septum, into that wall a bit further if there was an abscess. So I think it's perforation.
Interesting. Okay, back to you, Carl. Let's try and speed this one up a little bit. Let's have a look at this bottom right image. What is that image and how did I get it? Do you want me to make it bigger?
If you can. So it looks like it's at our pulse wave Doppler at the I suspected the pulmonary valve because it's labeled as pulmonary acceleration time.
Yeah, nice.
We don't have the VTI trace. We have the acceleration time 131, which is normal. How did we get it?
Yeah.
I cannot tell from your image how you got it.
Okay, fair enough.
I'm guessing it's a gastric view.
Yeah, nice.
Turn to the right for an RV outflow.
Yeah, cool.
But that's only a guess.
And what else do you have to do with the probe? So you've looked here. So gastric view, looking to the right.
I can't remember.
Oh, just a bit of anti-flexion, sometimes a bit of lateral rotation.
Wiggle around a bit till you get it.
Yeah, that's fair enough. But yeah, I think you're right. So it's this. So they call it that sort of RV inflow outflow view. So gastric or deep gastric, full anti-flexion, looking to the right, and sometimes a little bit of lateral movement. I find it's one of the only views you have to put the wheels different. You sort of have to move the wheels in different ways, and then I kind of put my thumb between the two of them to stop them falling back on each other. Is the way I normally do it. So anti-flexion, lateral rotation. Nice. That's just pretty. Right. Okay, last ones. Yeah, Carl, keep going. That was too easy for you, so I have to go this one. What is this showing?
So I think this is a mid-esophageal zoomed-in view of the mitral valve at 0 degrees.
Yep, and they're both frozen, so they're still pictures, both of them.
Yeah, so it's showing mitral regurgitation, which is central in nature. There's a continuous wave Doppler on the left, which shows a regurgitation jet, which is steep, is peak, but is not particularly dense. And on the right, for the color Doppler, it's showing central regurgitation. There's flow convergence. There would be what I would suspect is a wide vena contracta greater than 0.7, but we would need to measure that on this zoomed-in view. It looks like the alignment would be appropriate, and a regurgitation jet that's taking up less than half of the left atrium.
Okay, let me think what the prompt would have been for this. Why is there regurgitation? Oh yeah, what phase of the cardiac cycle are we seeing regurgitation?
Yeah, so given we have a patient with severe acute aortic regurgitation, we'd worry about diastolic mitral regurgitation. And there's two peaks on our, going back to our continuous wave on the left-hand side, there's two peaks, and the smaller one is in diastole, which would be consistent with diastolic MR. And then going back to our colored Doppler and trying to find where our tracer is, it looks like it's at the end of diastole.
Wicked. So yeah, if I'm ever showing you, if you've got an acute, if we're talking about severity of aortic regurg, and we think we're dealing with a really messed up aortic valve, and I show you a mitral valve regurg, just don't forget about diastolic MR. Very nice.
Yeah, so all those measures about severity are irrelevant because it's diastolic.
Yeah, very nice. Exactly right. Right, Michael, back to you. You said you wanted to see the hollow diastolic flow reversal. So again, we've now got on transesophageal. You were worried about planes of assessment and that kind of stuff. What do you think of these ones?
I'm going to start on the right side of the screen while I think about what the left shows.
Oh, that's just descending aorta. Sorry, that was just because I had the picture.
I'm not sure if there's something else associated with it or if there's just some fluid adjacent.
Oh, sorry,
to it.
It's got a bit of a pleural effusion. Sorry, yeah, don't get distracted by that.
Okay. Okay. So this does demonstrate some diastolic flow reversal, but it doesn't extend. It does extend all the way to the end of diastole, but it doesn't quite reach that end diastolic velocity of 0.2 meters per second. In a severe acute AR, sometimes you don't achieve that because there's a rapid equilibration of pressures with the LV chamber. And so I'm not sure if it's the perfect measure to decide upon severity in this patient when we have multiple other things pointing us towards this being a severe acute process.
Yeah, great job. I was also wondering, and that's the end of it. You guys are beautiful. Well done, everyone. That was excellent stuff. I was also wondering whether this has something to do with lacking this hollow diastolic flow reversal, may have something to do with the fact that it's a bicuspid aortic valve that's a bit stenosed, and whether we've got this perforation versus, abscess. Maybe are we just like Rob was talking about with eccentric jets? Maybe it makes that LVOT different. But there was no way that I was going to call this moderate regurgitation, not with the 2D looking like that. And I just think it's a really nice example for me about the importance of, seeing the whole heart, having that diastolic MR, raised left atrial pressure, utterly messed up aortic valve on 2D imaging, chaotic, eccentric looking flow on color Doppler. That for me trumps any kind of diastolic flow reversal in here, and it's important of clinical, and then you start to say the importance of clinical context. I mean, this lady was on like 5 of metaraminol, normal blood pressure, wanting to get out of hospital. It's extraordinary. So it's an awake, it's an awake sedation toe, and I was just I got to say I was a bit surprised by the severity of the regurgitation. It was extraordinary. Joe, I'd love to know your thoughts.
I was just wondering, how much of an effect does the dilatation of the aorta have on
nice.
that flow, that kind of diastolic flow?
Yeah.
Would it
very,
make
very
does
nice
it make
question,
it less?
yeah.
Does it affect the Windkissel effect? I don't know. Do you know?
I don't know the answer to that. I mean, I've certainly seen people with dilated aortas who've had severe AR, and we've had diastolic flow reversal in the aorta. So it's a really great question. I mean, this some of these images are pretty recent, so I haven't quite maybe figured it all out yet. But it's a great question. So maybe there's a bit of elasticity or a little bit of regurgitation, or just because you've got a wide structure, you're going to reduce the volume that comes through. It can sort of be taken up a bit more. It's the Windkessel effect. Okay.
That's what I thought. Yeah.
Great suggestion. When we put this in the exam, I'll make sure I put that in pass or fail. You've got to say the Windkessel effect, or you don't get the marks. Nice. Cool. All right. Case 2. Where are we up to? Rob? STEMI, short of breath, and on a cardiogenic shock.
Okay. So first image on the left is a deep parasternal long axis, and so we can see straight up that the LV systolic function from this view looks probably severely impaired. Right ventricle normal size, aortic root and aortic valve appear to okay at this stage, and just looking at the mitral valve, looks like it's coapting okay. And just looking behind the heart, there are some B lines reflecting off the pericardium, which could be consistent with the cardiogenic shock state. Looking at the mitral valve, we can see that there is, from this parasternal view, some mitral regurgitation, which I'd like to quantify further in other views. So just to summarize, the anterior septal wall and inferior lateral wall are both hypokinetic, at least from these views. So this is a still image measuring the LV internal dimension end diastole, and so just going through 5.8 centimeters. I can't remember the gender of the patient, but that's a male patient. So it is dilated. It's not quite in the severe range yet. The LV wall thickness is normal, and it appears to have been measured correctly. The end diastolic volume I would ignore at this stage.
Yeah, nice. How do you know? You said it's measured correctly. Can you just tell me what you look at to make sure the measurement is correct? How do you do it?
Sure. So firstly, it needs to be an end diastole. So that will be, I tend not to use the ECG, but I'll use the part of just prior to the mitral valve closing. So the frame just prior to the mitral valve closing, and then we trace, we ignore the RV trabeculations for the interventricular septal thickness, and we measure that up to the.
That's good. We'll move on. That's great.
Tissue interface. Yeah.
Don't worry about that. That's no waste of time. Okay, what are we measuring here?
Okay, so this is looks to me like we're probably in the parasternal short, and we're measuring the RVOT, VTI, and the pulmonary valve acceleration time. So the VTI is significantly reduced, which would be in line with the reduced cardiac output state, and it appears to have been measured correctly with the closing click. The pulmonary valve acceleration time is not in the normal range, but not in the severely deranged range. So less than 100 is when I get worried.
That's beautiful. So talk to me about mitral regurgitation, and we're going to talk about severity and etiology, please.
Sure. So just looking at this valve, firstly, I like to look at the 2D structure. Looking at the posterior leaflet of this valve, given that the anterior lateral wall of this ventricle is akinetic, really, the posterior leaflet is restricted in motion, and you can see with the color flow Doppler that there's an associated eccentric jet, which would be in line with that etiology following the posterior wall of the left atrium. We then have, I guess, a zoomed in view or a reduced depth view of the left ventricle here, which is showing that severe systolic impairment. And you wanted me to concentrate on the mitral valve, so I look at the continuous wave Doppler here I guess this shows a couple of things. Firstly, the maximum velocity is significantly reduced for a mitral regurgitant jet, which would be in keeping with the low cardiac output state. We could measure that with a DP to DT. It's not triangular shaped, which was what you'd expect in severe MR, but it's reasonably dense. But I'd like to look at if we could get some pulmonary vein flows. That would be good to help assess the severity of the MR. Looking at the colour, we can measure a Pisa radius. We could also measure the vena contracta if we zoomed in and looked at that. So
anything else?
We can also use continuity equation to measure the severity of MR. So if, we can then equate both the effective regurgitant orifice area. So if that was more than 0.4, that would be severe. We can measure the regurgitant fraction. If it was more than 50%, that would be severe, or the regurgitant volume would be more than 60 mils is severe.
Nice. And then just the E prime going forward greater than 1.2, but
yes,
that's a big thing. Blah, blah, blah. You kind of told me about that. What are your numbers for DPDT?
So it's not something I do regularly because it's sort of prone to measurement error, but more than 1200 is normal from memory. Yep. I feel like less than 800 is reduced.
Perfect.
Yeah.
Fair enough. And as you said, it's a bit of a terrible measurement, but it's just, if you're going to measure it, you measure it like this, where you've got 1, maybe 2 cardiac cycles filling it, where you're interested in filling the screen, and it's just that time difference between going from -1 to -3. So it's quite nicely done there by the sonographer.
Yeah.
Obviously, I wouldn't do it. And then you asked for pulmonary vein flows.
Yeah, so it's difficult on transthoracic imaging, but just having a look. So
that's right, it's a bit rubbish. But what would you be looking for?
So what I would be looking for is, in severe you have systolic flow reversal. In moderate it can be just blunted.
Blah, 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 blah. Very nice. That is absolutely sensational. Passed well for me, that one. Well done. Well done. Okay, who's next? Drew? Okay, unwell, fevers, rigors, new loin pain, thought to be pyelonephritis, and then there's hemodynamic collapse with rapidly escalating catecholamine requirements.
Okay, so this is M mode. It's on a peristernal long axis, and it's indicating that they're likely a left ventricular outflow tract obstruction occurring.
And how is that occurring?
The ventricular walls appear thickened qualitatively, but I think quantitatively as well. The left ventricular chamber looks relatively empty. This could be due to hypovolemia or reduced systemic vascular resistance in the context of sepsis. Hypertrophic cardiomyopathy is a consideration as well.
Yeah. So you talked about the ventricular hypertrophy, but you said the LVOT obstruction. How does that obstruction, happen?
This occurs due to the Venturi effect. So due to flow acceleration, there's essentially a drop in pressure where the anterior mitral leaflet is pulled in within that flow acceleration and cause an obstruction.
Yeah, nice. Just wanted to hear Sam. That was all I was after.
Oh, yeah.
That's pathology noted, man. Yeah.
Okay, peristernal long axis view again, and it's I guess there's 2D features that are in keeping with our concern. But other notable findings, there's severe left atrial dilatation, and the right ventricular chamber looks.
How do you determine severity of the obstruction?
The severity of obstruction can usually be assessed with the gradients at rest and with Valsalva. To be considered obstructive is over 30 millimeters of mercury using continuous wave Doppler and apical 5-chamber view. But some of the data suggests around 50. And of course, incorporating that with clinical features of the patient.
Nice. The last one I'm just going to mention is the period of time that that anterior mitral valve leaflet is touching the LVOT septum. So if we go back on this, this is often why we've done it. If it's more than a third of diastole, it's suggesting severity as well. So yeah. Blah 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 blah. Let's go for this. How do you tell the difference between an LVOT obstruction versus mitral regurgitation?
So mitral regurgitation is a pan systolic jet, whereas the LVOT occurs after the closing click, or the closing click of the. Sorry.
Yeah. So after the closing click, what's that period called?
The isovolemic relaxation.
Yeah, nice. So that you don't have the isovolumetric contraction phase as well. So yeah, so the MR it starts early. It's not with the closing click, it's more sort of the opening click, to be honest. So mitral regurg often starts earlier in the cardiac cycle because you've got flow during isovolumetric contraction, as opposed to the valve's got to open for you to get the LVOT obstruction. So you've got so the mitral, it's all about timing. So mitral regurg is broader than the LVOT obstruction. Yeah. So it's all about So timing is how you tell the difference. Yeah, nice. I've given you the marks for that. Cool. Joe. Case 4, 25-year-old male. 2-month history of shortness of breath, which is worsening. Pitting edema to the thighs. Hypoxic with basal creps. No family history or drug use.
Young chap. Okay, so parasternal long axis view with severely impaired LV systolic dysfunction. The LV doesn't appear dilated here, but I'd need to measure it to be accurate. The RV appears to be a normal size. Can't see anything grossly abnormal with the valves in this view, but I can see some consolidation behind the heart, but no pleural effusion.
Beautiful. Did you tell me about the right heart?
Yes, I said the right heart appears a normal size here, but I'd need to see in the views.
Nice.
So apical 4-chamber view. So starting off with the LV, again, there's that global severe systolic dysfunction. The walls aren't thickened or thin, and it doesn't appear dilated here. So I'm still kind of a bit unsure of what's causing his symptoms. The LA is a little generous here. Just seeing if there's any bowing of the intra-atrial septum to the right to see if there's any raised epilectoral pressure. I can't see that, but I'd expect LA pressures to be raised, bearing in mind the poor systolic function. The mitral valve is opening enough considering the systolic impairment. And then looking at the right side, the RV is not dilated. The TAPC appears normal with a normal RA size. I can't quite see the RV free wall, so it'd be good to get a fractional area change to see what the function's like there, especially with the clinical signs of peripheral edema.
Yeah, what do you think might be the etiology of this?
Well, there's LV systolic dysfunction, so there's definitely a global problem with the LV in this young chap. So whether that's LA pressures raised and then there's raised pulmonary pressure, which is causing his other symptoms. But I think I need a bit more history and a bit more imaging to see exactly what the cause is. I can't see complete regional wall abnormalities. It's all kind of global. So we're going to need a bit more investigation.
Yeah, very nice, fair enough. So rubbish question. Okay, so talk to me about assessment of diastolic dysfunction. I'll give you these parameters.
Yeah, so a few parameters to look at. So if we take the top right hand, that's the mitral inflow And what we want to do is look at the E velocity, which is 1 here. So it's getting to the top end of indicating diastolic dysfunction, because we normally look for greater than 0.5. The bottom right is a continuous wave Doppler through the tricuspid valve looking at the TR. So we're looking at our RVSP here to indicate pulmonary hypertension as a consequence of raised left atrial pressure. And we're looking for a Vmax of greater than 2.8, which that is here. And then we've got on the two left images, pulse waved investigation of the mitral annulus from septal and lateral. And for the septal, we want it to be greater than 0.8, and for the lateral, it's greater than 1. So these are impaired. So overall, this is at least grade 2 diastolic dysfunction.
Any other parameters that you could use that I haven't given you?
We can have a look at the pulmonary vein as an indication of raised left atrial pressure as well. So I'd be looking for blunting of the S wave or even S reversal, but definitely blunting of the S wave. You can also look at M mode with colour Doppler through the MR to look at the slope of the I can't remember what it's called. There's the slope of the colour.
Velocity propagation.
The velocity propagation to see if it's very sloped, then that's an indication of raised of diastolic dysfunction. What else is there? I can't think of anything more.
There's no problem. Remember, it's not the MR for the velocity propagation, it's the forward flow. It's the inflow into the
forward flow. Yeah,
nice. I was just trying to get at things like deceleration time.
Oh, yes, of course.
So if it's less than 140, that's a sign of severity. Greater than 240, that's kind of normal. E to A ratio, greater than 2, pointing towards severe. And then there are things that I think are sort of maybe more linked to research side of things, which are things like the TAE index and the timing difference between isovolumetric contraction and the ejection time. And do we mention left atrial size, interatrial pressure? So the intraatrial septum being pushed over. So we do love kind of asking these kind of very broad subjects to ask you to explain them in about 45 seconds. So just have that. I would have thought for each of the valves, for stenosis and regurgitation, just a little brief overview, a nice systematic way of doing it. I think probably the same for diastolic function, and maybe the same for fluid responsiveness. Just something that you can quickly just rattle off in terms of some measures, broad brushstrokes, headings only. That's sort of time. I wonder how. Should we just do it? Let's just quickly finish off. Oh, so Michael, you've got a question.
Sorry, Professor. Could you go back to those tissue Doppler tracings? Where would you call the E prime there? I might just be displaying my complete ignorance.
So again, I'm going to use that as the E prime is defined as the first drop down, I would have thought, after the isovolumetric relaxation. So that could be, actually, to be fair, that could be either way. But here you can see a clear thing of the isovolumetric relaxation. So I'd be measuring it, that one there. And remember the last one, it reminds me of the last one we talked about, which is the B bump. So here we can see this kind of 3 pattern thing almost. Is this isovolumetric contraction, maybe? So I think probably it's the E and the A now I come to think about it. E and the A, maybe that's isovolumetric contraction, and it's just got a bit confused. Those are around the wrong way. But B bump on pulse wave Doppler is another good one of the inflow.
Thanks, Sam.
Who wants to finish this off? Where are we up to? Whose turn is it? Is it Kyle? Are you happy to go finish this off? You took us to the beginning.
Yep.
So this is, I stole this off I don't know if you guys read Case, if you're a member of the American Society of Echo, but if you are, this is a great journal, Case. So it's excellent echo study. So 55-year-old guy, short of breath, PND and lower limb swelling, same as the first one.
So this is a transthoracic echo apical 4-chamber review. The most striking abnormality is a grossly enlarged right ventricle with, I suspect, severe impairment of systolic function with some preservation of longitudinal function, and what I suspect is going to show free-flowing tricuspid regurgitation with no movement of the tricuspid leaflets on view. There's also a very prominent, what looks like a moderated band seen in the right ventricle. The left ventricle function looks fine, but there's clear movement of the interventricular septum towards the LV, certainly in diastole, suggesting volume overload, but also potentially in systole, suggesting pressure overload. The mitral valve looks fine compared to the rest of it. So this is the RV inflow view. Showing the what used to be tricuspid valve, showing free flowing tricuspid regurgitation into the right atrium. It certainly would be severe, but a term like torrential would probably be appropriate.
Very good.
So this is a continuous wave Doppler through the tricuspid valve on an apical 4-chamber. This is first of all, this is not going to accurately reflect the pressures given the severe right ventricular dysfunction and the wide open tricuspid valve. This is a perfect example of the caveat for estimating pressures, but this shows us early peaking with a velocity less than 2.5, which is certainly going to be underestimated the right ventricular systolic pressures. Top left, on the left is a pulse wave Doppler through the hepatic vein, which appears to be showing systolic reversal in the hepatic vein, interesting of increasing amplitude through those free beats, and then a collophone Doppler showing the same thing.
Very nice. What's the diagnosis?
55, eh? I don't know, does he have some sort of chronic pulmonary pathology?
Yeah, anyone?
Carcinoid.
Carcinoid. Good job, carcinoid. So this is a very sort of classic feature for carcinoid. That wouldn't be pass or fail for the exam, to be honest, but it could come out. It's just the American Echo Board exams, they love asking this because there aren't many things that just fix open your tricuspid valve like that. We had a call here from maybe Ebstein's. I mean, I think Ebstein's has got a greater difference between the mitral annulus and the tricuspid annulus. Normally that's got to be anywhere from sort of less than 7 millimeters. So the tricuspid annulus is always above the mitral. But as it gets over 7 millimeters, that's when you start to get the Ebstein's, and the tricuspid leaflet still moves though. So it's with carcinoid, they say absolutely fixed open, and you get that torrential TR. Great term, because that's only come out in the last 18 months to 2 years. That extra diagnosis of or that extra classification of normal, mild, moderate, severe. Now it's torrential as well. Indeed, they're suggesting that the classification also includes whether you've got impingement of the pacing wire in there as well. So I think that's probably what we're going to see in our careers, is this a reclassification of tricuspid regurg with that. And then as you picked up, that rapid pressure equalization there and that triangular shape sign with severe TR, very, very nicely done. And then systolic flow reversal again pointing towards the severe TR. I feel like I didn't teach any of you anything there that today. You just smashed it. Everyone smashed it all. That was absolutely brilliant. Are there any questions from anyone? I thought you were sensational today. Okay. Guys, I'm really sorry. I'm about to go away on. Sorry, I'm not sorry I'm going away on holiday, but I am going away on holiday for a month, which means that the last 4 sessions I won't be taking you. I think the next time I'll see you, we're seeing some of you at the exam in the beginning of August. Please, if you do have any questions for me, I'll be on email. I'll send out some written questions before I go. But just wishing you guys all the very best of luck. I think your knowledge and your exam techniques are all absolutely flawless. So just stay calm and answer the question. And I have no reason to suspect that all of you aren't going to ace this. So just be calm, be systematic. The cadence you've got, the way that you're talking is absolutely sensational. So best of luck. You're going to have Ben Gahadi. And Ben Cardi, who's one of our echo reporting doctors, a respiratory physician, but amazing at echo, and he's got his FASC and DDU. He'll be taking it, as well as Santosh, one of our cardiologists and PhD candidates, and Hatem, thank you very much, and Hatem Elkandi, who's one of the other DDU candidates, an old echo fellow of us, who's one of the intensivists at Westmead, who's kindly going to be taking a session as well. So I hope you enjoy their time. And again, if you've got any problems, please reach out. And really all the best of luck to you guys, okay?
Thanks, Sam.
Thanks so much,
Pam. Great.
Take care, guys. Bye.
Sam. See you later. Bye.